Hi, everyone. Welcome to the webinar. My name is Jay Cranston. I'm a marketing manager at Signifier Medical Technologies, and we are very excited to have you here tonight, and also our presenter, Beatriz Elizabeth Carmona Toro.
Hi.
So I'm just going to give a little intro on Elizabeth, kind of a description of what the presentation is going to be about, and then also go into a little bit of the Q&A. But thank you, Elizabeth. We're very excited to have you here. So a little bit about Elizabeth. She received her bachelor's in nursing from University of Central Florida and her master's in nursing practice from the University of Central Florida, and then became certified as a family nurse practitioner. In 2011, she joined the Neurological Services of Orlando with a practice focusing on sleep medicine in addition to general neurology. With efforts aimed at the education of others, she's spoken locally, including at the annual Heart and Vascular Conference, MS patient support groups, and has served as a preceptor to upcoming nurse practitioners. So today, she's going to discuss a novel daytime device, eXciteOSA, which provides treatment of mild obstructive sleep apnea and primary snoring without interfering with sleep. She'll go through case studies that highlight not only the impact of this new treatment, but also how to incorporate it into routine practice. You can type questions in, there's an inbox you'll see on the screen where you can type questions throughout the webinar. Some of them we can just answer via the chat. Some of them we may stop throughout the webinar and Elizabeth can answer herself, but we'll probably leave a lot of them for a Q&A at the end. So feel free to ask questions throughout the presentation, and I will come back on and help moderate those. But without further ado, I will let you take it away, Elizabeth. Thank you.
Great. Okay, so hi, everyone. As Jay mentioned, I do go by Elizabeth, and I'm a nurse practitioner. I've been working in sleep for over a decade now. It feels like I kind of blinked and the years just went by. But what I'm hoping to do is take that experience and be able to use it for everyone here today to explain to you a little bit about what the eXciteOSA device is, and then also give you an idea of how it fits into some real-world practice scenarios. So we're just going to go into the typical agenda kind of slide here. This is what we're going to cover: some clinical data, a little bit about sleep apnea, a lot about how the device works and some treatment options, and then some screening, how we're going to identify patients, and we'll wrap it up with a couple of case studies of some real life patients. So to give you some context about my background so you know where my perspective comes from, it's a private neurology practice that I work in. There are several physicians. I'm one of 2 nurse practitioners. The services we have are pretty typical for a neurology office, lots of different types of tests. That does include home testing. That we've had that available for, I want to say, more than 5 years. But the last 2 years has been weird time-wise, so maybe it's longer than that, but it's been available for a while. The pathways for how we see patients, of course, there's that initial consultation, which can happen just from a direct referral. It's always great to have some context and some background for a patient. So definitely appreciate the referrals, but we do actually see patients that are basically self-referred. The patient themselves identifies they're having a major issue and they just contact us and say, I need this evaluated. So that's actually worked out great. It's not appropriate for many specialties, certainly not appropriate for neurology, where it's better to have another provider determine if neurology is the right specialty. But for sleep, it tends to work pretty well. The patients identify that they need some help. Testing, if it's appropriate for the patient, home testing, in-lab testing, they have their pros and cons. I'll touch base on that a little bit later on. So obviously that's something that's discussed during that initial visit with the patient. And then we'll consider treatment options if that patient has sleep apnea. Obviously, this presentation is focused on obstructive sleep apnea and how we manage those cases, not about other sleep disorders, but just give an idea of how the patient goes through the process and how I deal with that. So a little bit of background on snoring and obstructive sleep apnea. You see those prevalence numbers there on the left. The sleep apnea number is pretty interesting. It's 33%. That was a study that was published in 2019, so those numbers are relatively recent. The important part there is to notice that there's 55% are in the mild range. And I'll talk in the next slide a little bit about the different severities of sleep apnea. I'm sure people in the audience have some familiarity with sleep apnea, and maybe some don't have quite as much familiarity, so I'll cover that a little bit. But I think the important part is that there's a large majority of patients that have sleep apnea that are really in this mild range. So what does that mean? What does that look like? It's not always the stereotypical middle-aged 400-pound male patient. So we need to kind of expand our idea of what sleep apnea patient look like. So I'll get in touch with some of that later. Now, the second box talks about the natural history. Patients often ask, how long have I had this? Is it going to get worse? And the answer is, it will get worse, but just very gradually as we get older. Like many things do get worse as we age. So we see here that second point, it says the AHI, which is the apnea-hypopnea index. That's basically what, it's a large part of what tells us the severity of sleep apnea. The hypopnea, so those are partial obstructions, desaturations, and those are all going to worsen as we get older. I basically tell a patient that gravity does what it does, and as we get older, everything gets a little more saggy, a little more droopy, and that's going to include the back of the throat, because what, of course, we're dealing with here is the back of the airways collapsing, and how often that happens is going to worsen with age. The third box here on the right is basically to point out how sleep apnea is not just impacting the patient themselves, it's also really impacting their bed partner. You're going to often hear, if you work in sleep medicine, countless times how the patient is presenting with the primary complaint of, I'm here because I'm getting kicked out of the bedroom. My snoring is so severe, I can't stand it anymore. My bed partner can't stand it anymore. So it's not only snoring, but the sleep apnea also is going to impact more than just the patient themselves. And it's critical to focus on treating their primary complaint. And that's there because there was a study that actually looked at how sometimes we lose track of what that chief complaint was. The patient themselves is not always the one that's significantly being bothered. The sleep apnea is a little tricky sometimes because the large part of what's happening is happening when the patient is asleep. So they may not really be aware of the worst part of it. They may come in only because there's that bed partner complaining about things. So just a little bit of an overview there. And you can see there's lots of references on those data. If for some reason you want references, I'm sure we could get them to you if anybody wants that later on. You can mention it into the chat and we'll get you those. This slide, I think, is really interesting because it's going to give us an idea of the devices that are available to treat sleep apnea. So because obstructive sleep apnea, and I always mean, when I'm saying sleep apnea during this talk, I really mean obstructive sleep apnea. The back of the throat is collapsing. All of the treatments are going to be dealing with that airway structure. And across the top, you'll see the severity scale. So that goes from left to right. The apnea index, 5 events or less is actually considered normal. So you'll see that labeled there as primary snoring. 5 to 15 episodes is mild sleep apnea. 15 to 30 is moderate. More than 30 is severe. And I always tell patients who are severe, they basically have fewer options. So you'll see that in the columns there. On the left at the top, we've got the eXciteOSA device. That is actually approved for primary snoring and mild sleep apnea. Studies are ongoing for moderate, but the data you're going to see today is really on snoring and mild sleep apnea. And then we'll talk about, obviously, how exactly it works. The positional therapy, the example of that is wedges or pillows or belts that are going to keep the patient off of the supine position, trying to minimize the frequency of their apneas. They can help, certainly. It has a lot of limitations just with a patient being compliant with that. The oral appliances, they certainly have their place. That is going to be a custom-made device. It's top and bottom. So some of you might be familiar with oral appliances for teeth grinding or for different other dental issues. But the ones that are made for sleep apnea have to be top and bottom because the key there is to move that lower jaw forward and create that space here to open up that airway. So that is appropriate for mild sleep apnea. In some patients, moderate sleep apnea patients, that's labeled there if CPAP is refused, or just the patient chooses to try the oral appliance. The next one is the CPAP, and you can see that is approved across the board from mild sleep apnea all the way to severe sleep apnea. The CPAP stands for continuous positive airway pressure. Those little separation there, you see APAP or BPAP, it's all positive airway pressure. Will it technically work to fix the apnea? The short answer is yes, it will. It's far more difficult is, will the patient be able to tolerate it? Can they use it every day? Because it doesn't really fix anything long-term. It fixes the apnea in the moment. So the biggest challenge, as I'm sure many of you know, is getting the compliance from these patients on the CPAP. And so there's a lot of time spent with getting that to happen. But it is the most common treatment, basically. The other treatment listed here is the implantable device. I think it's branded as Inspire. Some of you may be familiar with that. It's implanted here. I always tell patients, you leave pacemakers on this side. This device is implanted here. This is considered a second-line treatment, basically because of the requirements to qualify for it. Someone has to try and fail CPAP first. There's also a limitation based on weight. I believe the cutoff is at 32 on the BMI, and it's not really appropriate for patients who are mild. The Inspire device may not fix all of the apneas, but the idea is these are patients who have not tolerated other treatments, and they do need to have some sort of improvement. This slide is limited to devices, so I didn't want to skip over the fact that it doesn't cover surgical treatments. So in case there's any ENTs in the audience, I'm not forgetting that part. The surgical options are there. I always tell the patients if they want to be evaluated, we can refer them. It really depends on what part of the airway is causing the problem if surgery is going to be appropriate. It's just there's no going back from that. So a lot of patients would choose a more non-invasive approach before they're going to try surgical treatment, but I'm happy to refer if that's what the patient is interested in. At the end of the day, this is really about trying to meet the patient where they're at and find the treatment that's appropriate for them. Because no matter what I think is going to be best for them, that may not be the treatment that they're going to be comfortable with. So it's good to just have a reminder of the different treatment options. And so that's what I wanted to make sure we got across on this slide. So now let's learn a little bit more about the eXcite device itself. Okay, so the slide has some important information on it. I'm not going to read it to you. I'm just going to show you the device. So I've got one here. And the biggest points to remember are listed there. Is it's non-invasive. They wear it during the day. It's 20 minutes. The treatment course is it's 20 minutes every day for 6 weeks, and then twice a week for maintenance. So this is kind of what the device looks like. Give an idea here. It's a Bluetooth controlled device. It pairs up to the patient's phone. They have an app that they can control the intensity with. So that is usually a concern from patients, is that there is stimulation happening. Is it painful? The answer is no. They can control it. So it hasn't really been a challenge in, I'm going to say, real world, is patients haven't really complained of it being painful. It feels odd. Now, I tried it, so it does feel odd, but it doesn't hurt because they control the intensity. So it does have these contact points on here. So it's 2 on each side. It's very flexible, comfortable to use. They wear it for 20 minutes. So what that's doing is it's increasing the muscle tone of the tongue. And that's really the goal, is it's going to increase the muscle tone of the tongue so it doesn't then fall back and block the airway. So I explain it to patients that way, that we have a device that is going to increase their muscle tone, and then they have to maintain that muscle tone. So there's a maintenance phase to the treatment, but it's first 20 minutes a day every day, and then just twice a week. So what I'm going to do now actually is jump into a quick little video clip that's going to explain that with some great graphics for us. So here goes on that one. This should work just fine.
With the aim of improving endurance of the upper airway dilatory muscles, eXciteOSA provides a novel daytime therapy for patients with mild OSA and primary snoring. The compact device supplies low-frequency neuromuscular electrical stimulation, NMES, via 4 electrodes that rest directly on the tongue, stimulating the upper airway muscles. Simple and comfortable to use, the daytime therapy requires only 20 minutes of NMES each day to increase responsiveness and prevent excessive relaxation of the tongue muscles during sleep. According to clinical research in skeletal muscle stimulation, NMES has been shown to result in a change in myofibrillar protein expression to induce a phenotype shift from fatigue-prone to fatigue-resistant fibers with the strengthening of the cytoskeleton. In summary, eXciteOSA's innovative, clinically proven daytime therapy trains the tongue and upper airway muscles to be more resilient against mild OSA and snoring.
Okay, so now you have a great explanation visually and in a wonderful British accent that I can't do. So basically, I saw a couple of questions there. It is a device that has to be prescribed. At the end of the day, it's a medical device, and the patient purchases it. But I'm going to get back to the data, and we'll get to some more of those kinds of questions at the end. So here you have the impact of eXciteOSA as measured during their studies. First is on snoring. There is a significant reduction in snoring. You can also see there's a reduction in the volume of snoring. So if it doesn't completely resolve the snoring, it is having a really good improvement on how bothersome the snoring is because of that reduction in volume. The second box is the self-reported sleepiness and sleep quality. So that first point is something called the Epworth Sleepiness Scale. For those of you who aren't familiar with it, the Epworth Sleepiness Scale is a standardized scale that has 8 questions. The maximum score is basically 24. Basically, that's somebody who's dozing off every chance that they get. They're any sedentary situations. The reduction of 3 points is really significant. So out of 24 points, maybe you'll have a patient who on the initial visit has a score of maybe 14 or something like that. So if that's dropped by 3 points, this is a patient who is less likely to doze off in a meeting or less likely to fall asleep, fingers crossed, not when they're in traffic. So it is an important point. The second point there is the Pittsburgh Sleep Quality Index. So that's a much more detailed scale. It's very standardized, been used in research for a long time. It's like 30 questions or so. It is going to ask patients about how many times they woke up during the night, did they wake up feeling rested in the morning, these kinds of things. It's a little difficult to quantify sleep quality, but the fact that there was an improvement in this very standardized scale in the studies is obviously important. And then also the bed partners noticed there was an improvement in the sleep quality index. So sometimes when we treat sleep apnea, you'll see the bed partners say the patient now sleeps better, they're less restless, they're not waking themselves up snoring. So it's nice to see that even the bed partner noticed that. And I just wanted to quickly mention, apparently the device does not always require a prescription. So I'm sorry I was incorrect on that. In Canada, that's different. So we'll cover that more in detail, I'm sure, and clarify it at the end. Okay, so back to this. The sleep efficiency is also an important point to make. If you're not familiar with it, the sleep efficiency is basically a measure of what the percentage is that I'm actually sleeping of the time that I'm spending trying to sleep. So if I spend 8 hours in bed trying to sleep and I've only slept 4 of those, it's really bad sleep efficiency. If I'm in bed 8 hours trying to sleep and I actually slept 7.5 of those hours, that's actually really good sleep efficiency. So this difference here, that it increased from 75% to 84%, is telling you the patient is more likely to wake up saying, I slept better. And I think that kind of ties right back into that their sleep quality seems to be measurably improved. Okay, so what about the sleep apnea severity itself? At the top, you see it's the apnea-hypopnea index. So if you go back to thinking about the severity of the sleep apnea, the AHI, less than 5 being considered normal, 5 to 15 is mild. If we're talking a reduction of 33%, that does make a difference in how many episodes they're having. It's also important to see that there are some patients who are 52% better. So how does that make sense? If we think of the anatomy of the airway, it depends on the patient where the obstruction is really coming from. So some treatments are going to be more effective in some patients than other treatments. So just as an example of that, if a patient has really large tonsils, then that's part of the obstruction. The eXciteOSA device, as you saw in the video, is focused on the tongue and some of the upper airway muscles, but primarily the tongue. So if the patient has really large tonsils, that's not going to have as much of an impact as if the patient doesn't have tonsils. Maybe they were removed, they don't have issues with the upper palate possibly, but really is the tongue that's causing the obstruction. So if the tongue is the obstruction, then the eXciteOSA device is more likely to be effective. So it does depend a little bit on the anatomy of the patient, which treatment will work more. And so in real world practice, we will see that there'll be some patients that one treatment is more effective than another. The same is true for other treatments like an oral appliance. In some patients, it will be more effective than in other patients. The second box here talks about the oxygen desaturation index. So that is the frequency of desaturation. In the sleep studies that you see, often on that report, it will only really say the AHI. So it might be on the second page or in the detailed data that you'll see the ODI, the oxygen desaturation index. So this is about reducing the amount of desaturation that the patient is having. And clinically, that's important because when we think about how sleep apnea is related to other conditions, how it tends to worsen things like cardiac arrhythmias and the risk of stroke and those types of things. There's the relationship really is about the frequency of desaturation that is happening in these patients. So if we can have a significant improvement of that, we're making a difference in these patients, in their long-term risk. So something to think about, that there is a measurable improvement in their oxygen level. And then that last point is the adherence, which if you practice in sleep medicine, that's one of the biggest things that's challenging with sleep apnea, is getting a patient to be compliant with their treatment, whatever the treatment is, whether it's the CPAP or the oral appliance or the eXciteOSA, the adherence is important. So it's great to see that it has a couple of reference points on that line, because there were two different studies that the adherence was actually pretty good in the 80s, so 85 and 86 is listed there. And I'll tell you that after dealing with patients in this treatment for over a year, that's pretty consistent with what I see in practice. We're all, creatures of habit, and the treatment for the eXciteOSA is that daily treatment over those initial 6 weeks. So those first 2-3 weeks can be a little bit difficult to really make it a routine. And so what I find is that most patients will work it in towards the end of their day, and that first week they may miss a couple of days. So seeing this 85, 86% on the studies is actually pretty consistent with what I've seen in my own patients. They get there, but the important thing is that adherence is still enough to be able to create a measurable impact. Of course, perfect adherence is what we're aiming for, but this is the real world information, so that's good. Okay, what about the statistics in snoring? So we talked about the numbers with the apneas, but it's even better with snoring. So 90% of snorers actually experienced a reduction in the snoring. Their bed partners all agreed with that. So if you're treating a patient who is complaining of snoring and maybe on the testing did not have actual sleep apnea, but their quality of life is being impacted by snoring, then it's good to know that their chances of having an improvement with the eXciteOSA are actually pretty good. Similarly, that last point there, in sleep apnea patients, they also reported that improvement in snoring. Sometimes snoring is their primary symptom, sometimes not, but that improvement was also noted in that patient population. Okay, so we've gone over a little bit about the treatments available for sleep apnea. We've gone over about what what the impact of the eXciteOSA is on sleep apnea and is on snoring. Now, what do these patients actually look like when they come into your practice? Some general symptoms of sleep apnea there. I did want to point out that it's not always very obvious. I mentioned the patient might be having trouble staying in the same room because their bed partner is talking about, their snoring is not tolerable, but sometimes it's not that. Sometimes it's more subtle. The patient may be complaining of just fatigue, and they'll say, I've seen this often, is they'll say, I'm tired of being tired. And I'm here because I've already been checked for other things. And this is the part that I mentioned, excuse me, is the part I mentioned that it's great if someone has already seen the patient because they've screened for those other things. They've screened, they've had the routine physical, the patient has had blood work for thyroid issues and these types of things. So all those things have been considered, but this patient is still tired. They're still waking up tired. And they might even be having morning headaches, for example. So, we have to consider those patients, that it's not always, I am snoring, I am having apneas. It may not be that obvious. And so being aware that a patient who is complaining of being tired might actually have sleep apnea is, I think, something important to keep in mind. If you're in a setting that screening tools are a good thing to add, there's the Stop Bang questionnaire is a screening tool for sleep apnea. The Epworth Sleepiness Scale I mentioned before. So this may be a patient who does complain of fatigue and has had some routine labs, for example. Now let's do some sort of screening questionnaire and then identify that patient if they're appropriate for testing. And to touch base on what that would look like, a little bit about the different types of testing. And it does really depend on where you're practicing. which type of testing is accessible if you're somewhere that has a lot of labs, sleep labs nearby. Home testing, I'll date myself a little bit and tell you, it wasn't really around when I started practicing. And I didn't really like the idea of it when it first was introduced, I have to admit, because I'm so used to the data that comes from an in-lab study. There's all kinds of information that we get from that type of test, and the home test doesn't have that. So basically, there's no technician to apply all these sensors to the patient. With we get heart rhythm and leg movements and stages of sleep and all of that with the in-lab test. But with the home test, I lose that information. So I have to admit I had some trouble adjusting to the reality of home sleep testing, but it is very convenient for the patient. It certainly reduces the cost, but it is not perfect. So that red dot there is, as I mentioned, maybe cardiac arrhythmias. That's a patient that's going to be appropriate for in-lab testing. And it also has nothing to do with central apneas, which is a whole separate thing. I do want to point out the limitations of home testing. You might have a test that comes back invalid. If you're highly suspicious, the practice guidelines certainly say that you should consider that patient for in-lab testing. There's also the thought that home sleep testing doesn't know when the patient is awake or asleep. It measures only if an apnea is occurring, if a desaturation is occurring. And it gives you an apnea index, but it's per hour of recording, not per hour of sleep. So it is possible to get a home sleep study as a result that tells you a patient has an apnea index of 3.8. That's technically normal. And then their oxygen level dropped, but it dropped to the mid-80s, for example. If you are, as a provider, suspicious of sleep apnea, you have a patient who has 6 or 7 different symptoms, that home sleep study is likely not sufficient. You are missing sleep apnea there. It's very likely that patient does have mild sleep apnea, but maybe it took them an hour to fall asleep, or maybe they woke up in the middle of the night and they were awake for 20 minutes. All that recording time is there, but the patient was awake and breathing normally. So it's just something to be aware of, that there is a place for repeating a test, or really considering a patient is more appropriate to go into the lab. So that can happen. I understand that home testing has increased the access that patients have to sleep testing. There might be in more rural areas, and may be difficult for them to get to a sleep lab, for maybe they're a caregiver to someone in the family. So I'm glad that home sleep testing is around. I've come around to appreciate the home sleep testing, but they're not perfect. So that is important to keep in mind. Now, I wanted to, at this point, before I jump into the case studies, just give Jay a chance to chime in and see if there's any specific questions that we needed to try to address at this point. Let's see. Okay, I'm going to go ahead and keep moving along. So the first case study is Mike here, obviously not his actual name. Mike is a 29-year-old patient. He was a patient who I think was really concerned that he was having a significant issue, because he had been told that he had trouble breathing while he was sleeping. I think someone actually had recorded him, and so he didn't realize it was that bad until he saw the video of himself gasping. So he came in really concerned. Did not have any major health issues as far as comorbidities, was not on any type of prescription medication, but did have a lot of symptoms suggesting that he had sleep apnea, or that he might have sleep apnea. So in that initial visit, we discussed some pros and cons of sleep testing. Because he did not have comorbidities and there wasn't any concern of a home sleep study not being sufficient, we went ahead and we did his home sleep study. You'll see the results there. That was an apnea-hypopnea index of 7.4 that was found, and his oxygen level did drop to 82%. When we followed up to discuss the treatments, he was right away leaning towards the eXciteOSA device. And the primary reason, well, there were two main reasons for him, really. One of them was he did have to travel for work, usually at least once a month. Obviously, that frequency had changed during the last couple of years, but typically he would have to travel for work at least once a month. He did not like the idea of having to carry around a CPAP machine. And he was also concerned about the social aspect of having to use a CPAP machine. He mentioned he was in a relationship, but if he had to spend the night somewhere else, how's he going to carry that? So the fact that the eXciteOSA was something he could use during the day and have some improvement on that snoring especially was a big factor for him in choosing this treatment. So that was actually a quote from his follow-up visit there. So the usage in the first 20 days was just actually 11 out of 20 days. Not great. And I did mention that's one of the common challenges is making it part of that routine. Fortunately, though, he already felt like he was having a benefit. He was actually waking up a bit more rested, which was great to see. And he had no doubt that the snoring had improved. So he was, I'm all in. He was basically like, I can do this. I didn't start off great, I can admit it, but I can do this. So I'm actually looking forward to seeing him on follow-up to see what he's doing. And I will touch base on, in the next case, on how we do some of the follow-up on these patients. Okay, so now a completely different patient would be Kelly here. So she is a 46-year-old patient. She was initially diagnosed with sleep apnea several years ago. Tried CPAP. She did for over a year. We went through a lot of different masks. She had a really hard time finding something that was comfortable, that would fit her face. And her symptoms are listed there. She did have some trouble staying asleep during the night. Her biggest concern was the snoring. And it was sometimes a debate of between her and her husband, who's going to spend the night on the couch. So that's not a great place to be, obviously. After she tried CPAP and had so much trouble using it, she decided, I'm going to focus on weight loss. I'm going to lose weight, and this is going to go away. So she did. And she worked at it, and she lost 50 pounds and was really excited to get retested. And so we did that, but her sleep study showed she still had significant sleep apnea. So her index was at 14. Her oxygen level dropped down to 86%. She still had enough of a problem that we needed to address it with treatment. And she was actually still snoring, and it was still bothersome. So when eXciteOSA was available, she was also excited to try it. And you can see that quote there. She was going to make sure that this worked. So you see the adherence over the first 42 days was actually 98%. She was not joking. This had to work. She had tried. She had tried just about everything else. And we had discussions about all the other treatments as well for her. So she's too mild to qualify for the implant. She had already had tonsillectomy, at least. The oral appliance, she had some history of TMJ issues, so she was worried that wasn't going to work. So we'd considered multiple treatments. So this is one of the most consistent patients that I'd seen in terms of adherence. She was very happy with the outcome. You see there the post-eXciteOSA HST. So that's an important point, is most of us are used to, if the patient has a CPAP machine, we're getting feedback on what is happening with them really regularly, right? We can see that their apnea index is estimated. It's an estimate the machines give us, and it estimates that their apnea are improved or their sleep apnea is treated. Okay, so how do we determine if the eXciteOSA device is being effective on this specific patient? And so after the patient has completed that initial 6 week of treatment, the idea is you do a test then to see what has changed. Has their oxygenation improved? Have their frequency of apneas improved? And that's basically what was done here with Kelly. In her situation, there was a significant improvement in the apneas, and the oxygenation is better. The snoring was much, much better. So she was very happy with this outcome. And you can see it may not correct every single apnea, but it is creating a significant improvement for a patient who otherwise was having a really hard time trying to find treatment and was really looking for something to be able to help her. So it was important to make sure that she had access and had the option of considering different treatments. I'm going to, in the next slide, show you a little bit what it looks like on the provider end of things when we talk about seeing the patients and how they're doing on the device. Before I jump into that, I just do want to acknowledge a point that Kelly brings up for me, which is, thinking about Kelly brings up for me, is the challenges that may be a little bit more specific to women when it comes to CPAP. The masks are not fun to wear. Everybody knows that. But they may be more difficult to find a comfortable fit in women, maybe more petite features. The headgears may not fit. So the fact that some of these masks are bulky makes it more difficult for women to find a good fit. I know the mask manufacturers is something that they work on, certainly, but I have seen more of a challenge with women and having that work out for them. And then I think of a patient who was actually very compliant with her CPAP, very consistent with her CPAP, except for Wednesdays. And I remember having a discussion with her, and it was not Kelly, it was a different patient, but having a discussion about why she missed every Wednesday. What is wrong with Wednesday nights? And it turns out it wasn't actually Wednesday nights, it was Thursday mornings. Thursday mornings, she went in and had a meeting with all the directors, or basically all the leadership in her workplace, and she had to present and lead Thursday mornings. And so she could not have a meeting first thing in the morning with the strap marks on her face from the CPAP machine. So if I had not asked her specifically about that and been able to pick that out from her data, I wouldn't have known that that was a challenge for her. Otherwise, her answer was, yeah, I'm doing fine. I'm sleeping fine. It gets a little tricky sometimes with patients, and we really have to, I think, dig into the nitty-gritty of what's happening with them and what their challenges are about why they are or not being compliant with their treatments. So fortunately, I remember with her, we had worked on trying to find a way to avoid that, so she wouldn't feel like she had no choice but to miss treatment because she was going to have this meeting and then marks on her face. So that's something that I think is maybe a little bit more of a sensitive subject in female patients, but I've tried to give the patients a chance to discuss that, because whatever treatment is chosen for them on this side of the table sounds good. If on that side of the table is not something they can actually do, then what have I really accomplished for them? So Kelly, I'm very happy to say, is actually doing great with her eXciteOSA. And I can tell you that 98% adherence was something her and I had discussed on that follow-up. And the reason would be there's a portal for providers. So this is just a sample snapshot. It's not specific to any particular patient. But what you can see as a provider is if one of your patients is using the eXciteOSA, basically you can have some data that shows you how often they're using the device, what is their average intensity that they're using it. It tells you the day that they started treatment. So as an example, if the patient has a device and you're not sure how long after your visit they started using the device, this portal gives you access to that. And I think it's great for people that are used to going over CPAP data during a visit. This gives you something to review with those patients. And it also reinforces to the patient, hey, you're doing a great job. I can see you started using it. I can see that intensity level increase. And just so we understand what the intensity level is on the device is there's the 20-minute algorithm. The device is going to fluctuate that intensity, but the patient chooses the initial intensity where they start at. And they do have control of that even during each session that they're using the device. So if something feels too intense, they can change that. So I do try to remind patients to help them with the adherence really, is that there is no minimum goal for you must get to this setting. It is use it consistently. As you use it consistently, you will see that the setting that you started with on the first week is not the setting that you can start with on week 3. It just turns out, I could barely feel that. Now I start higher. So the algorithm the device has, it helps get them there, but the patient can choose where they start. So that's important. I never want a patient to feel like they have to absolutely hang in there with a really intense kind of simulation. That's really not the case. So having the portal, I think, can help have that conversation with the patient so they get some feedback about how they're doing with the device, and also motivate them to continue to use it, knowing that it's something that we can kind of coach them through and I can see with them. The portal does also show when the patient has entered in phase 2. Phase 2 being after that initial 6-week and they're on that maintenance. As a tip to patients, since it's supposed to be twice a week, I tell them pick 3 days. Try to, say 3 days on the schedule, so in your mind. So if something comes up and you miss a day, then you don't just completely fall off. So think Monday, Wednesday, Friday, but if you happen to have missed Monday, then you've got Wednesday and Friday. If you did it Monday, feel free to skip Wednesday. So the goal is twice a week for that ongoing phase. And there's several patients that I've seen have been able to do that. Okay, so at this point, what I'm going to do is say thank you for paying attention, and I'll let Dave jump in so he can do some questions.
Awesome. Thank you so much, Elizabeth. This was great, and I'm really happy that we were able to have you on, and thank you everyone for joining. It's exciting to see that there are new treatment options for mild sleep apnea. We know that it's tough when you have mild sleep apnea and you're wondering what's out there, how you can get help.
Yes.
And it looks like you've got a really great approach of really screening those patients and understanding which ones it makes sense for. And just seeing those cases, it's really great to see that it is working for these patients. And we're excited to have this new therapy option for them.
Yeah.
So there are several questions, so I'll just jump in. One of them was asking about whether it's covered by insurance, so I just wanted to jump in for that question. So fortunately, CMS did establish reimbursement HCPCS codes for us, so they became effective April 1st. So we are in the beginning journey of that. The MSRP is $1,650, and it depends on your DME, but the cost could be anywhere between $800 to $1,000. But we are seeing patients submit claims already for insurance, and some of them have gone through. So it is still very early, but we're very excited because it's been a great year, and having that milestone hit back in February really has been exciting. So hopefully that answered your question. And then we've got just quite a handful of questions that I will shoot out to you. So one of them was, can the 20 minutes of use per day be split into 2 10-minute treatment sessions?
I don't think so. I think the algorithm has to run that 20 minutes. And I think it has I started it, I put it on, and something came up. And so if I stopped it, I want to say it's those first few minutes. Maybe within 5 minutes, then it'll let me restart it later.
Yep. So you have an option to take a 3-minute break, but if you go over that, then you need to start over. But it would be done in one therapy session.
Yeah, and I think the most practical point that patients have found to use it in is that at the end of the day, when they're going to then get ready for bed, that seems to be the most popular moment to do it. But I'll tell you, just I did try it, and it's distracting. But I was able, just as an example, I was able to pay attention to the kids walking around the room, and I was folding laundry, and it was fine. So it's not so intense that you can't do anything else. I don't think I could work while I had that on, but you can find different ways to fit it into your day. And I have had patients fit it in primarily towards the end of their day as they're going to relax before they actually go to bed.
And that's interesting because, I've talked to patients where it's part of their morning routine. So as they're getting ready every morning, they just use it in the morning. So I did see that was a question, whether it's better to use at bedtime. Really, I mean, I just say if you're watching Netflix, doing your emails, whatever, reading a book.
I think the important part is being consistent. And then what we're doing is trying to build that muscle tone. So it's like any workout. You want to build that muscle tone, and then we're going to maintain that muscle tone. So having that consistency, wherever it fits into your day, is going to be the way to go.
Great. There's a question about follow-up study. So is a follow-up study required?
Okay, so that's a really good question. So from the clinical aspect, I would say it's recommended, because I don't want to have my patient on a treatment that is not effective for them. So if I have the sleep study that tells me they're at, like Kelly, for example, gave me an idea of what her apnea index was, and then I want to be able to say, this is effective, so you can have the confidence of continuing to use the treatment, knowing it's going to be effective. So that makes sense. And I will tell you, we've not had issues with having the home sleep testing in terms of coverage. That's not necessarily a cost for the patient, not in our area. And I think it's because we're doing a study for a clinical reason. There has been a change in the patient's condition that we're now reassessing. The same would be true if the patient had an oral appliance, for example, or they had undergone some sort of upper airway surgery. Something has changed about the patient, we then do a study to reassess that. That's not true with CPAP, so it doesn't apply because the CPAP is giving you some information. So there's no repeat study after someone has CPAP, but there is routinely a reassessment done after the oral appliance, surgical treatments, and then the eXciteOSA. It's recommended but not required, because let's say you're using this for a patient who has snoring. They don't have apneas, their oxygenation is actually fine, their complaint is snoring. So what would a repeat study tell you? Some studies can tell you like number of snoring events, but is that really what we're concerned about? Because the patient can tell you if they're having less snoring, or the bed partner can tell you if they're having less snoring. So it's not a requirement. It does depend a little bit on the patient situation. I will tell you that my choice is if the patient has sleep apnea, the recommendation is to reassess that patient. Not necessarily true for a patient with snoring. Hopefully that answers the question.
Great. Yeah, no, that's perfect. What would you say your percentage of patients are on this therapy right now?
Oh, that's interesting. So it's been about a year since we really introduced the eXciteOSA, and I don't know what the last check was, Jay, but I think the numbers, over 70 patients, I think, are on the device from our office.
Yeah.
By and large, the large majority of patients do use CPAP. There's a reason the CPAP is the #1 treatment, right? It's been around a long time. It's primarily what the insurances have a preference for. That's the reality. So it's not, how can I give a percentage? I don't know that I can quantify that.
Oh, I think just, the 70 was great, knowing that there's that many people on it. That's really great.
Yes. I do discuss it. I want my patients making informed decisions. So any patient who is newly diagnosed with sleep apnea, this is being discussed as a treatment option. One of the reasons is I don't want a patient to feel that they're being forced into a treatment. Whatever their treatment is that they choose, even if it is something like CPAP, the patient needs to make an informed decision about that treatment. I'm not there to do it. I'm not there at night to put this mask on their face. I'm not there to make them put on a device. I'm not there to remind them to use the eXciteOSA, although the app does a great job of reminding them. I will say that. But I want the patient to make an informed decision and say, this is what I am choosing. So treatment is part of the discussion as treatment options for all newly diagnosed patients. And then it really just depends on what the patient preference is, because I'm trying to meet them where they're at so we can really have that compliance and that adherence with their treatment of choice.
That's great. And I think that's kind of exactly what I was saying earlier. It's nice to have these different options, and that you are very informed and make sure that you have the right treatment for the right patient, and you really have that great screening process. So I think that's great that you educate your patients on all the different options.
And we can keep it on the table as a later option too. They can switch treatments. So that's also important to know.
Yeah. Okay, we've got quite a few more. So have you seen any instances where eXcite causes tongue muscle hypertrophy that causes more obstructions?
It's an interesting question. Not that I have seen. I have seen where there's a few patients who post eXcite, we determined that it was not effective enough for them. And I think that really has to do with thinking of the patient's anatomy and where their obstruction is coming from. So I'm not going to say that every single patient has remained on it, but I mean, I'm going to say on our more than 90% of patients who have started this as their treatment have chosen to stay on it. But I haven't seen a case that has been made worse. I've not had a patient tell me that their tongue feels different. So something to, I guess, keep an eye out for, but not so far.
Right.
I don't think it's measured. I don't know that in the studies there was anything about it changing the size or the structure of the tongue. It is changing the muscle fibers, but I don't know that there was anything that was mentioned about the size of the tongue change.
Yeah, that's right. Does the intensity need to be adjusted based on clinical symptoms or the AHI of the patient?
Nope. So it's basically whatever, I think the recommendation is whatever the patient feels they can tolerate, and they're dialing it up. It'll say like, I think 4, 5, 6, 7. So they're dialing it up, not in like a technical hertz or something kind of measurement. They're saying like just 1, 2, 3, 4, 5 kind of on their screen. And so the recommendation is to start it at when they feel the stimulation, but they can't tolerate it. And then during the 20-minute session, it goes through an algorithm that is going to increase it. During that session, the patient has the option of decreasing the intensity if they feel like it's too much. And like I said, over time, when I start it, it feels, I can barely feel it. Now, fast forward 2 weeks, the same intensity I barely feel it. So I can increase it naturally. And the algorithm will help them do that, but there is no minimum that they're required to start at. What I like to see when I'm looking at the portal afterwards is just, oh, you used to start at 7. Now you're running it at 9, or now you're averaging 11. So I like to see that increase. So I know that they're building that muscle tone, but there's no goal of minimum cutoff to reach.
Great. Does this replace myofunctional therapy or an adjunct?
Myofunctional therapy. I don't know that I'm too familiar with that. As a treatment for mild sleep apnea? I don't know if I need to kind of dig into that one a little bit and see where it goes.
The myofascial therapy?
I'm not familiar with something that's specifically approved as a myofascial therapy for sleep apnea.
Yep.
Yeah, this is targeted specifically for the tongue.
Yeah, we can follow up on that question.
Yeah. If you have more detailed question that maybe we don't fully address, feel free to put it in the chat, and we can definitely try to get back to you and email the information. And I also mentioned that in terms of getting some of the references and things like that, we can also get those to you. There are obviously the references are things that are published, but happy to get those to anyone who has questions on some of the data.
Great. So there have been some supply issues that people are experiencing. Is that something that you've been experiencing with other machines or treatment options? And that's something that has come up in your practice?
Yes, it makes me squint, but yes. Anybody who has to deal with sleep apnea is aware of the recall from last year and the huge kind of imbalance that it's created as far as supply and demand when it comes to CPAP. I have had several patients who are choosing other treatments. Maybe if it was 2 years ago, they would have been happy to go along with trying a CPAP first line. But now, because there's such a delay, just today, actually, I was trying not to get too frustrated by it, but just today, had a patient who's saying, hey, I don't have my CPAP yet. And our staff is reaching out to the equipment companies, trying to find out whatever happened with their order from 4 months ago. And the patient is just in a waiting list to receive a machine. So, at that point, that's just not okay. I mean, that patient needs to be treated. So let's get them to a different equipment company that hopefully can do a little bit better on that timeline. There are definitely challenges that are outside of the individual equipment company's control about supply chain things, obviously, but my goal is just to get the patient treated. So in reality, is there have been some patients who have said, if it's going to take a couple of months or something for me to get a CPAP device, in the meantime, what can I do now? So that is a patient that might really choose to do eXciteOSA, at least to see if it's the right treatment for them, knowing that they can later then switch, try something else. Maybe, they will choose to do a CPAP long-term. Maybe not, but this is something that's available to them now, so they're going to move forward with this. That has happened. I can't say it hasn't. It's the reality of the situation right now. I think it might be different depending on where you're practicing and how bad the supply and demand type of imbalance is.
Great. Yeah, it's not a fun time, I'm sure.
No, it's a little painful to think about, how many patients get stuck in that.
Yeah. If you were to do a repeat study, when would you do that study on a patient?
So the main goal is to do it after they've done that 6 weeks of initial everyday treatment. It's not strictly 6 weeks. So a patient who elects to do the eXciteOSA, let's say I'm seeing them today, giving them the prescription, in our case with a prescription, and I will schedule that patient for follow-up usually in like 7 or 8 weeks. The reason is to make sure that they've been able to use the device. We go over the information from the portal, that's usually done. And then if they feel like, yes, this is something they can do long-term, yes, they are reporting benefits, okay, we have some consistent usage over those initial 6 weeks, we go ahead and do the sleep study. If that patient on that follow-up visit, it turns out it took them 3 weeks to get it, and that first week they barely used it, well, I have to know that and not order this home sleep study just yet. Maybe I'll wait a couple of weeks. So I really want to do it after that initial period of 6 weeks, because that's when the data shows we should have a measurable improvement. So I really don't want to do it before that 6 weeks. So usually it's some sort of follow-up to discuss it before I order the test.
Perfect. Great. Well, it looks like we're getting towards the end of the hour. There are a few other questions that I think our team, we can probably answer them offline. But yeah, thank you. I think this was really great, very informational. Again, exciting to have different treatment options out there now. So I don't know if there's any last words that you wanted to say.
I think just in general, keep an eye out for these patients. Think that the stereotypical sleep apnea patient is not the 400-pound person, and we need to be a little bit more open-minded and have a higher degree of suspicion for sleep apnea in general. So more treatments is good. It's not, what it was 10 years ago when I first started. So be aware of that and just keep an eye out for them. Yeah. And other than that, thank you for your time. Yeah.
Yeah, no, thank you very much for presenting. And again, thank you to the audience and everyone for joining. This will be recorded, so if you were having some issues with Wi-Fi or you wanted to watch the webinar again at a later time, it will be available on this platform. So thank you so much again, and I hope everyone has a great rest of your day.
Yes, thank you, everyone. Bye.
Thanks, Elizabeth.
Sure thing.
Bye.
Bye.